Hello. Welcome to the Health Foundation webinar, Getting into the Improvement Habit. We're sorry there's been a slight delay in setting this up, but we're delighted that you're with us. I'm Nick Barber, I'm the Director of Research at the Health Foundation, and I'll be chairing this meeting, and I'm joined by Professor Bill Lucas and Dr. Emma Vaux. Bill and Emma are experts in this field of improvement, and we're going to be talking about this report which Bill and others have produced, and Bill will explain the report, and then Emma will talk about some of the practical implications and also about a UK-wide task and finish for a report which is going to be coming out soon. Bill is well known to us in the Health Foundation. He's Professor of Learning and Director of the Centre for Real World Learning at the University of Winchester. And with colleagues at the Health Foundation, he's played a key role in developing the Improvement Science Fellowships and the application of this discipline into the workplace. He also works with the Vinvard Fellows in Sweden. Emma is a consultant nephrologist and a Director of Quality Improvement at the Royal Berkshire Hospital, and she is also an Associate Medical Director of the Royal College of Physicians. So we've got two experts who are going to bring you theory and practice, and we're going to coalesce those. You've got a role in this as well. It's your role to ask questions of them. And by the wonders of technology, you can submit questions. They should be you can type them in a box on the left-hand side of your screen. You can send them to me at any time. And at the end, I'll be going through the questions. After two 15-minute or so presentations, I'll go through the questions and we'll have a group discussion. So without more ado, I'm going to hand over now to Bill Lucas, who is going to take us through the report.
Nick, thank you very much indeed, and good to be with you, Emma. I want to make 3 lines of argument to you. I want to suggest that when we talk about improvement, it's for many in the service too abstract, it's too big. And when we flip from the big improvement idea and start talking about tools, we might be talking about driver diagrams or trigger tools or run charts or all the panoply of improvement method, that somehow seems too small. So the first argument I want to make is that perhaps there's something in the middle, and I'm going to call it habits. I'm certainly not the first to have done that. The second line of thought I want to share with you is that improvement really requires us to change our habits. So there's another very powerful reason for using the language of habit and habit change. And the third area I want to explore is to start a conversation with my friends and colleagues in education, all those people who either at pre-service or in service are looking at ways of teaching and learning the kind of improvement habits and the skill and the knowledge that we need everybody in the service to have if we're going to be successful. It's been long known that if we are to make improvement real, it has to move up from the any other duties section of people's job description. It has, as Paul Batalden and Frank Davidoff have made so clear, it has to become an everyday reality, an inescapable way of being when you're in the community, on the ward, or interacting with patients and service users. But there's a problem, because when we try and change a habit, even if it's a habit we want to change, it's tricky. Let's take the oft-cited example of washing our hands more often, cleansing our hands more effectively. If we took a conventional view of this, we'd say that the knowledge that infection is spread by hands which are not clean has been around for, well, a century probably. If we want to look at the skill aspect of washing hands, then again, the skill has been and is widely spread amongst the service. There are some technical aspects, and we may need to dry our hands carefully and use our elbows and have taps with long handles and so forth. The knowledge and the skill, the way this might typically show up in a piece of training, have been around for a very long while. So why is it that we still find it difficult, reliably, routinely, to wash our hands as often as we need to? Well, I think it's because although we have the knowledge and the skill, we don't necessarily have the habit. And in particular, we haven't perhaps got the habit of making the connection between the situation and context we find ourselves in and the need to wash our hands as clear as it needs to be. And if that change that we need to make is anyway different from our previous behaviour, we haven't yet made that routine. We haven't accepted the change. So nothing new there, you might say, but I think quite a lot of new interest with regard to improvement right now that makes the report that I and my colleagues, Hajar Nasser and others at the Health Foundation have produced, hopefully a timely one. There's a burgeoning interest in the science and craft and art of improvement. There's a considerable expansion across the world of courses and interventions in the area of what's come to be known as QI, or quality improvement. We looked at the UCAS database here in the UK, and we found 37 examples of postgraduate courses in the broad area of quality improvement. Here with the UK Centre, and I know we have some international colleagues, but with an NHS lens, the 5-year forward view intriguingly talks about the importance of learning, why would it not, in the post-Francis, post-staff's review, but it doesn't actually lay out, I don't think, and I'd be interested in Emma's view, a really clear practical implementation of how that's going to happen. We know, and I know that Emma's going to talk about this too, that we still don't get the buy-in we need from some clinical groups and indeed from some social groups. We have wonderful opportunities with the Clarks and the other initiatives like Clarks across the world where practice and research and come together. We've got great test beds for this, and Emma's work on the Medical Royal College's Task and Finish group has enabled us really to think very practically about how we might inject some of this work into the initial and continuing training of various clinical groups. I want to just pause there and take you into one other reason why I think now is important, and that is that I think we're only now perhaps beginning really to understand what it is that we're doing here, if you like, to have a compelling theory of change, which for me goes something like this, and I would want to acknowledge the wonderful paper by Frank Davidoff and Mary Dixon Woods and Laura Leviton in BMJ Quality and Safety, where they demystify the use of theory in improvement. So if we better understand the kind of habits that we think improvers need to have and the knowledge and skills with it, then we can get much better, much tighter in specifying the kind of learning that we need and the methods that are most likely to be helpful. So it's not just a question of adding something in. We can also, I think carefully about at what stage of your professional formation you need this learning, so that gradually we build capability. We build it at the individual level, we build it at the team level, we build it at the system macro level. So that ultimately that wonderful phrase of Don Berwick's that an ethic of learning truly will permeate the service. And I guess also the way we do this is not to do it to someone, but to have a model of health and care giving that is co-produced. So the learning that we're talking about here is equally important for patients and service users as it is for those working with them. One of my favourite psychologists is Thomas Ebbinghaus, and here is his well-known illusion. It doesn't quite look it on my screen, but I hope it does on yours. Those blobs in the middle are actually the same size. I'd like to offer it to you as an image of two kinds of approaches to improvement. The image on the left is an image all too often seen. There is the poor patient or service user in the centre, and around him or her are clanking any number of improvement methods, improvement tools, improvement projects, improvement initiatives, until it's almost wearisome. On the right, the same things are going on, but they're going on in an integrated, sustainable way. And they seem, by comparison, contextually, much less in your face. I think that image, culturally, is probably where we need to be. And at this point I want to introduce the notion of habits. It may not need an introduction to you, but for some it's a slightly different lens, a complementary frame, a way of looking at what we're doing in improvement in health and social care. I want to draw on a psychologist here, Lauren Resnick, and her work in thinking about real-world intelligence. I want to share a phrase that she has, one of my favourites, that one's intelligence is the sum of one's habits of mind. That being smart, if you like, having improvement intelligence in health and social care, requires one to have a certain set of habits of mind. If one goes to pieces, things go wrong, such as technology not functioning at the beginning of a webinar, hypothetically, that may not be helpful. One needs a certain resilience. If one only sees things from one's own perspective, that can be irksome, and so forth. And it was Lauren Resnick's thinking, allied to some others that I'll mention in a moment, that got us thinking about whether or not we could reframe the kind of things that we were seeing our colleagues doing in health and social care in terms of a language of habits. So for example, Kallick and Cole and others in the field of science, clearly a very relevant one to the biomedical disciplines that are so important in caregiving, have talked about habits of mind such as the ones that you can see on the screen here. What a different way of framing the scientific discovery that all scientists are keen on. To think about open-mindedness and objectivity, and I particularly like a mistrust of arguments from authority, probably sits quite well in terms of many of our colleagues in the health and social care services. So it's perfectly possible to reframe if you like, a hard discipline like science in this way, but if you do so, then it produces a different dialogue, a different conversation, a different set of foci. About 1.5 years ago, the Royal Academy of Engineering in the UK approached my small research team and invited us to look at the issue that we're facing in the UK, and I sense globally, and it's a supply and demand issue, or is it, that we need more engineers, but we don't seem to be able to get enough of them. And presented as that, it's often painted as a sort of leaking pipe situation, where we have young proto-engineers at primary school, but somehow they've not shown up when wanted at university level, and therefore we don't have enough of them. So we worked with the different engineering tribes. Can you see the read across here to medicine? And we looked with mechanical and chemical and electrical and all the other engineering groups, and we worked with them to come up with a set of self-chosen engineering habits of mind. And you can see them there in the middle of this ring. And we found that it was possible indeed to do this, which was of course a question. We didn't know whether it was, and that having done that, something really powerful happened. Two things actually. One, engineers stopped talking about which tribe they came from. And two, in terms of education, they began to have a really thoughtful and rich conversation about what teaching and learning methods might work best to achieve the target habits. So when with Nick Barber and Helen Crisp and other colleagues at the Health Foundation, we were having this conversation, we thought it might be useful to undertake a similar conversation with colleagues undertaking improvement. And that's where we've got to, and that's what we offer you. It's a work in progress. It's certainly not meant to be the final job. And already you should, as scientists, be right to be suspicious of any model that can be neatened up into 5, each with 3 sub-habits. But that's what we've had a go at. And I want you to imagine that you're walking alongside and observing somebody you know to be a really effective improver in a context that you know well. And I've done this often, and I've seen improvers at work, and they're special people. They're constantly asking questions. They are not just happy to deal with other people's problems, they're actively seeking problems of their own. They're endlessly reflective. They want to sit down after an event, after a process, and review it. That's the learning segment in the top left-hand corner. Moving round the imaginary clock face. They're great influencers. They don't assume that just because they have a great idea that everybody else will agree with them. Therefore, they have to be empathic. They have to read others to see where they might be coming from, the different, if you like, tribes. They have to be facilitative. You can't tell somebody to do something. You have to persuade and understand and engage. They have to be comfortable with conflict because, hey, not everybody's going to agree with you, damn it. And that's the nature of improvement in the real world. They also have to have certain attributes associated with resilience, both in an engineering sense and in a psychological sense. They need to retain their sense of joie de vivre and optimism in a challenging service. They need to take risks and to be prepared to be reflective as they so do. And they need to tolerate the essential uncertainty that many of us will encounter. They need to exert all of their creative juices to bring these things about. It's rarely that one works on one's own. I can't imagine that the Hadron Collider would have been created had it not been for a number of great scientists working together, or the DNA sequence unraveled without team playing writ large. But they need to be critical thinkers, because not all the ideas we come up with will be good ones. So they constantly need to be both coming up with and generating ideas, but exposing them to the lens of critical thought. And finally, but not finally in a neat sense, they need constantly to see this system of healthcare as not one that one can pull on a hard lever and expect something to pop out the other end. Complex, interrelated connections. So they need a synthesizing mind, and they ultimately need to be accepting of the kind of changes that this kind of thinking is going to bring about. So in offering this habits of mind perspective, we wonder out loud whether this might help us think more precisely about the kind of learning outcomes we want. Especially, and this is a pet interest of my own, to avoid curriculum developers and indeed improvers simply stuffing stuff into an already crowded curriculum. To provide a framework for good conversations. I was pleased to be up in Dundee recently talking about how we might use this frame as an appreciative inquiry tool to see where a whole trust was doing good work, or as a curriculum mapping tool to see how the initial training of doctors and nurses was covering all of these areas. I hope it'll act as a spur for debate. It would be very dull if we all agree with each other. And I hope it might make a modest contribution towards moving off the project idea into this being a job for life. And finally, I want to offer to you a notion that I think might be helpful here. If you're not used to either the word pedagogy or signature, forgive me. I think it's a powerful notion, and it's one that I want to introduce to you. Let me just go back for a second because I flipped on too quickly. Signature as in like the thumbprint, if you like, the DNA of it, and pedagogy as in the art and science and craft of teaching and learning. Because what we're talking about here is creating people who can do things when they need to be able to do them. It's not an abstract, artificial knowledge. It's close to Aristotle's idea of phronesis. It's a sort of contextually aware, practical smartness that we see so often when improvers are working effectively. Lovely paper by David Perkins and others, if you're interested in this. David, I think, and his colleagues have done more at Harvard in really understanding the complexity of learning transfer and how this can happen in a clinical care setting near you. In case you think there's no need for this, here is a recent paper by Molly Cook, Pamela Ironside and Gregory Ogrinker, which leaves us in no doubt that the current system is not yet up to the job. We too often use pedagogies which are perhaps too didactic and not real world enough. And it's not enough just to dollop in a bit of psychology, although I might want to see that happening, especially from such a distinguished psychologist as Jean Piaget. One of his favourite maxims, by the way, was knowing what to do when you don't know what to do. Perfect example of what improvers do all the time in a resource-strapped world. So back to this idea of signature pedagogy. What might it be for improving healthcare services? What might its thumbprint be? What might its inextricable DNA be? Well, I think we've got some emerging thoughts, and back to this proof of concept from engineering, where at the core of the thumbprint in engineering is the engineering design process. And I think it's not accidental that when you look at the engineering habits of mind that we were offering, you can see that whilst that might be a general technique, you can of course look at each of the 6 in this case habits of mind and see how different approaches to teaching and learning may be particularly effective. So what if we applied this lens to, say, the core learning method widely used as an improvement method and as a learning method within the improvement science domain, the PDSA cycle? What might that look like? Well, I think that might be close to the DNA of improvement science, and I think there are some others too. I think that when we're talking about signature learning methods, we need critical observation over time. We need sustained embedded opportunities for this. We need real assignments with coaching and real-time feedback. We need to teach our colleagues, to learn from our colleagues, to teach our aspiring doctors and nurses and allied health professionals and psychologists and pharmacists and the rest, the job of group critique, to see that as being essential to learning. We need to surround them with mentors and mentoring. We need to fill the space that they learn with inquiry-led processes such as, but not just including action research. And 2 more questions there I'd add to that. So to conclude then, I offer you, with my colleagues at the Health Foundation and the many people who've been significant in this development, one of whom in particular I'd like to honour Paul Batalden, who's been a critical friend on this journey. I offer you this framework and I leave you with 5 big questions, really. What might the signature pedagogies be, both at the general level and at the particular level, for building sustainable capability in a co-produced health and social care environment that's rich with communication, that doesn't assume these things happen like night over day? And at that point, I'm going to pass to my colleague, Emma.
Thank you, Bill. And I think the report which you and Hajar Nasser wrote is flying off the shelves at the moment. In fact, we've had to have a new print run ordered. So it's certainly piqued people's interest. And now I'm delighted to hand over to Emma Vaux.
Thank you. So from the theory to the practical, I'm going to describe the work that we've been doing over the past 5 years to try and create the right enabling environment for quality improvement to happen in practice, which is culminating in the work of a UK-wide task and finish group from the Academy of Medical Royal Colleges and its recommendations. So 5 years ago, the Royal College of Physicians launched Learning to Make a Difference, which was very much targeted at core medical trainees. And this is all about how could we move trainees from data collection, and essentially what clinical audit was in their hands and in most people's hands, and using data to drive improvement. And in order to do so, we wanted to enable the core medical trainees to learn, develop and embed skills in quality improvement. We used the model for improvement, lots of evaluation, and we learned an awful lot. But not least, actually this was of real benefit to patient care and very visible. But there was a lot of other learning. It was about setting expectations, demystifying the language, a need for support for the trainees, and also we do need our consultants to be doing this too. Since then, at college level, we've been able to influence the quality improvement agenda into the curriculum, into assessment, support with a small central core team, a website, resources, national showcase, international recruitment. But when you layer it down into the regional level, then sphere of influence becomes a little bit less, and it's using the supporting infrastructures already there, college tutors, training programme directors. Been very fortunate with 6 expert QI leads who help support across the UK, but that's a scarce resource and it's voluntary. But then when you get down to the organisational level, then sphere of influence dwindles completely. You can send letters to chief execs, you can send a DVD of the showcase, but actually we know from our learning that the local facilitation and support for trainees is absolutely critical. So we took that premise and how could we test that out? So as part of Better Training, Better Care programme, Making Every Moment Count was all about how could we do this in one organisation for every specialty of every grade. And again, it was a big success. It felt very transformational. But what we needed to make this happen and to be successful was that this needs to be core hospital business. It needs to be aligned with trust strategies, and you need that core team to support. But even more so, the power was when this was multi-professional and working with patients. So it's not just about the doctor. So we learnt that trainees can make a difference, but they need capability, resilience and support to do so. But where should we go from here? And that's when the publication of 3 seminal reports really changed the landscape, I think, for patient safety and improvement. And that really told us we needed momentum and a coordinated effort to enable quality improvement for all doctors and the teams with which they work, but to do this at a scale and pace that perhaps was not happening. And it's interesting, revalidation came along. I was quite excited, quality improvement part of that, but actually you just get a sense that it's more data collection. So a year ago, 25 different organisations came together as a UK-wide task and finish group under the Academy and sponsored by the Health Foundation and by Health Education England. And it was all about how can we get quality improvement into undergraduate and postgraduate training for doctors. And yes, the focus is on the doctor, but we absolutely recognised how important this was to be multi-professional and with patients, and I think that's been reflected in the makeup of our task and finish group and perhaps the real strength of the task and finish group. The decision was that we would have 4 work streams: curriculum, quality improvement training, resources, and then that glue, how it sticks together with the supporting infrastructure. First, we needed to get a consensus on definitions. And it's always interesting doing definitions by committee, but we went for the easy option for quality, so that's based from the NHS Constitution, but then very much more thoughtful around quality improvement itself. That this was about understanding complex healthcare systems. It's about a systematic approach, about testing change, real-time measurement, and that this was all about making a difference to the quality of patient care. But underpinning that was then quality improvement education. So having some knowledge, skills, but skills in managing complexity, leading change, learning and reflection, sustainability, but also training in human factors, because those impact on our capabilities to be able to make improvement happen. So here they are in a nutshell. And what's interesting with Bill's report is that when you layer the 5 themes, particular themes coming from the habits of an improver, this really seems to resonate in how they layer on top of what we're trying to do, and I think make even more sense and start to reframe how we look at this. So we come to the recommendations and curriculum. And certainly this was not about trying to stuff more into the curriculum. This was very much about how could we change the curriculum to be doing what we really wanted it to be doing. And this is about a spiral curriculum, about learning, activities and outcomes, starting with the medical student. How needed to be high level and flexible, and we needed to adapt what was already out there, and very much structured around the new GMC generic professional capabilities. And these recommendations particularly levelled at certain organisations such as the GMC and the medical schools. And this is the recommendations here. It's clearly a very busy slide. You will recognise that it's based around knowledge, around skills, around behaviours and values. And what is coming is a curriculum creator tool, which was first established by the previous NHS Institute, where several bodies since then with the Academy, and this is being resurrected and reinvigorated, and not just looking at patient safety, but from the improvement side. So hopefully it will become a useful tool for those developing their curricula. But the big challenge is around assessment. Should we be assessing for quality improvement? Should it be these supervised learning events? Should it be that it's in our professional exams? There's nothing like having an exam with being tested on it to make us do it. But is that the right thing? And then we come to resources. And what we mean here particularly is around people, expertise and time. It does include the supporting infrastructure and the physical resources that are available and examples of really good practice with signposting. But the overwhelming emphasis from this work stream was that we work together, so we should learn to improve together. and how best can we do that? And that's really where we come to the interprofessional education, both clinical and non-clinical. And there was much exploration of interprofessional education, and certainly seems to be a lot of methodological weaknesses. What's the impact? Quite short-termism, a lot of self-reporting. But we do recognise that interprofessional education can enable collaborative knowledge, skills and attitudes, and that has an impact on collaborative practice, and that there's emerging evidence that it does improve patient care. So we also need to give regard to how we learn in the workplace. And that would be learning through training, through information, working with others, and how we do that on our own. And certainly there's a lot of programmes in place out there already to support those. The recommendations are that there should be a vertical integrated thread of interprofessional education around quality improvement, science and human factors and ergonomics, that it's not just in the medical curricula, but is in everybody's curricula. And as the workplace is where the majority of our learning takes place, then workplace learning needs to be integrated into our work. No doubt a challenge there. There were 4 particular emerging themes to take that further, that quality improvement is integral to all our clinical encounters, that we have this interdependent collaboration between sets of professionals, but we should co-learn with patients and families. And then coming back to assessment, maybe we should be broadening that into what are we doing as teams in terms of outcomes and systems of care. And as Bill drew out, that we need this network of mentors and a network of useful resources to help support this. And then we come to quality improvement training. 4 themes: that it's important, it's essential, there's a lot of generic elements, and we need to think about the fact we're in the 21st century. So coming to quality improvement is important, that it's of benefit to patients, that it needs to have that parity with research, that everybody needs access to it, everybody needs time to do it. And then being essential, maybe we need a back to basics approach. Maybe we should be thinking about quality improvement as the new CPR. CPR is seen as common, basic, not comic, sorry, common, basic, a universal element that's easy to understand. And even if you're not doing it, you understand the basic principles and you can be called upon if needed. That training is not just about quality improvement skills, it's about teaching, it's about how do you write a report, how do you publish, how do you present, but also understand values that not every quality improvement change does work, but there's a real value to the learning from that. And then we come to the generic element. So quality improvement activity is in a multi-professional environment, so shouldn't our learning and training be in that multi-professional way too? And coming to the 21st century, dragon screaming to with digital element, so digital technology really critical here, but also about using all the different learning methods to create the hook in and then build from there. And then we come to the strategic infrastructure. So this is beyond the physical, this is the people. People as a resource for expertise and an enabler to facilitate the learning and implementation. And then the policy that's aligned with a strategic underpinning to provide an overall direction for a shared purpose, so that you're bringing together the different bodies, such as LEPBs, Royal Colleges, Commissioners, Health Education England and its equivalent. We took a different approach here in this work stream. It was an action learning event of over 60 people coming together with a buzz and energy, and we identified 4 important areas for recommendations. So around training and education, leadership and culture, co-production and communication. So with training and education, we think that there should be a national group or think tank with senior representation from bodies such as outlined there, so that we have a unified and multi-professional approach to quality improvement training and education, that there's a critical mass of quality improvement expertise and we're creating a common language. That we also want to provide education and training to assist the national regulation and commissioning bodies to really understand the power of using data to drive improvement. And then with leadership and culture, gosh, how important is the commitment, the buy-in, the role modelling and mentoring at board level? And to take that a step further then, in terms of, we really think that there should be a mentorship scheme that's very much championed by such bodies as the Royal Colleges and Specialist Societies. That we should be co-designing true outcome-based commissioning approaches that are aligned and align incentives with quality improvement, but to do so at organisational level, you need core quality improvement support to enable that to happen. It's not enough to say that the mantra that quality improvement is everybody's responsibility. You need the support to realise that. It just doesn't happen by itself. And then to co-production, patience. There's patient voice, but very much about co-design and co-production and understanding what are the priorities to take forward. And of course, communication, the shared language, but also sharing the good, the bad and the ugly about what works and what doesn't and how we can learn together. So what next? The report will come out by January. Is it just going to be another report that collects dust? That's certainly not the intention. The intention is that this is just the start. How do we put those recommendations into practice? But I do think there are a number of elephants in the room. So in terms of the chestnut about clinical audit versus quality improvement and how that's presented and understood, senior clinician engagement, the parity of esteem with research, and also time to do quality improvement. And maybe we can draw some of those areas out. And just finally, I want to say a big thank you to everybody that's been involved. It's been a huge joint effort. And as I say, I think this is just the start.
Thank you very much, Emma. Well, I think that was a tour de force. We saw interesting synergies from the two different approaches, and then a lot of thought about the practical implications, how to try and make this happen in the real world. We do have questions coming in from you. Please continue to ask them and send them in. So we will tax your brains now with this first one is from an applied health researcher at the North Thames Clark, saying that they're interested in the use of the term habits. How much is improvement down to habit and culture versus policies and procedures?
Thank you, Nick.
You can answer the issues about world peace afterwards. But
it's a blend of them all. But I think the interesting thing about using the habit word is that it's slightly closer to other words that leaders tend to use. Emma used the word behaviour and values, and I think habit is a good connecting into that. Leaders often talk about transformational leadership, and they forget that, of course, the most important element here is the culture, the organisational culture. And a habit at the individual level is a routine at the team or organisational level, and is therefore the underpinning of an organisational culture. So I think that habit, and I'm delighted to hear very recently that the Chief Medical Officer for Scotland also thinks this, is a really helpful lens when it comes to thinking about this.
yeah, okay. Do you want to add anything, or?
No, I mean, it's always around the difference between the climate and the culture, isn't it? And the sort of procedures and policies that underpin kind of set the climate, and then the culture is kind of layered on top.
Yeah.
But I have to say, I think it's all a big jigsaw.
Yes.
I think one influences the other. I'm not sure how you can separate it out.
Yes.
But for me, it does really come from the top. That will really set the tone. You can try and do lots of wonderful things within your organisation, but if it's that improvement is not seen as the main driver and that's the real core to your culture, then it's always going to feel a bit of a battle instead of, actually, this is the way that we do things. And I was very interested in your comment about job for life, because I think that's what it is, and that's how it should be seen.
Yeah. Well, that brings me nicely into one of the other questions here, saying, how do we get attention of senior management and even board members into this way of thinking? And this question points out the sort of aviation seeing itself as an improving culture, and health, although it says it's not, they feel sees it is still a blame culture. So how do we get this way of thinking up to people higher up in the organisation?
So from my perspective, it's about what's the hook. And I think the hook is very different. But if you're looking at board level, a lot of this is about your data, how your data's presented, understood, how you measure, and the visibility of what you're doing. But that it's aligned with what, as a trust, you want to be doing. But I think it is having that discussion around what may be a very heavy quality assurance agenda versus a quality improvement agenda. And I think it's how can you change the balance between the two. So for me, it's a lot about what is it that as an organisation you want to be improving, how you then enable your teams to facilitate and support them to be doing work that's aligned in that area, and visibility of results. You need some quick wins to begin with, but it's then getting it embedded. It's how board reports are written, lots of visibility about what's happening, and that you're stimulating conversation. So you move just from superficial quality assurance to understanding what's underpinning, what are the issues going on, really understanding what's driving that, so that you can start to improve it. Open and transparent culture.
And we tend to use Deming a lot, who is one of the people who transformed the Japanese manufacturing industry with these approaches. But the other American guru that transformed them was Duran, and he talks about the three circles, of quality improvement and quality assurance and quality planning. Because sometimes I think when you have a stable system, you can't keep improving everything all the time. You stabilise the system through quality assurance, don't you? And that gives you the stability on which you can build as well.
Yes, I mean, I think Deming's interesting in so many ways. I mean, he talks about nothing changing without personal transformation. And I think that we have to accept that we have to get leaders personally to become transformed, as well as to spout the mantra of whatever it is they need to think they need to spout. And I think that Emma dangles some sticks in front of us in terms of revalidation, in terms of compulsion, in terms of assessment. And I think we actually need to look at those very carefully. And I suspect we probably need all of them in different ways, although to achieve a level 3B at quality improvement is probably not a helpful concept. I think any high reliable organisation, when you listen to their leaders, they talk about learning. They talk about learning from, they talk about learning with, and they see this as a formative part of their journey towards getting better. And so it's a no-brainer that if that's the stick, Emma, that you were dangling, there are some carrots too. And I think carrots are often best, I'm going to mix my metaphors here, eaten or shared by really passionate leaders who run great organisations, who are showing how you can succeed at all the conventional metrics, but are also showing how you can succeed at these metrics too. So having their rigorous stories, having rich case studies that show that, having rigour. So as you said, Emma, it can't just be self-reports, but there are lots of ways of auditing in a good way, the kinds of climates and cultures that we're talking about, but not as a one-off event.
So there's a next question is one which I think you brought up slightly, or you mentioned in your talk, but I think it's probably worth revisiting given the two talks together, which is the questioner asks, are you suggesting habits as an alternative to knowledge and skills?
Absolutely not. I can't conceive of knowledge and skill in a vacuum. We need deeply knowledgeable, very skilled clinicians and caregivers right across the piece. But as I suggested, unless those arise when you need them, that knowledge and those skills are kind of nice to have, but they're not terribly useful in terms of improving patient care. So I think it's a parallel complementary lens. It's a way of seeing knowledge and skills. And what we tried to do in the report is actually, which I think again it would be wonderful if there were organisations out there who'd like to come and play with Emma and me as we think this through, is to map both a conventional knowledge and skill axis against some of the habits, to map some of the drivers that board members are looking at against some of the habits. And that was the kind of conversation, to go back to Tayside and Dundee, that we were beginning to have earlier in the week. So if you're out there and listening and would like to come and explore with us, I think we're just at the beginning of this conversation, but unequivocally it's not an either or, Nick. It's a both. It needs to be embedded.
Yeah. Would you add anything? Or?
Yeah, no, I mean, we talk about competencies and so the knowledge, skills and behaviour, and I think the word competent does turn off a lot of people.
Yes.
And there are the other words such as entrustable professional activities, which I have to say is even more. Yes. So then you talk about competencies in practice. Could you talk about the competent habit? And I mean, I like the term habit because that then implies that you're doing it as part of your everyday.
Yes.
But you do need to have something that underpins that. We know from the work that we did, you can have lovely, enthusiastic, committed people, and that's always a joy. But to enable improvement to happen in a robust, rigorous way, then you do need some knowledge and skill behind that.
Absolutely.
And some, expertise, just giving that kind of virtual hug to take you forward. Because however altruistic you are in wanting to improve patient care, you've got so many different competing demands that you need somebody, others alongside to help facilitate and support and enable it to happen.
Yes, another noun, Nick, that I find helpful is disposition. If you're disposed to do something, it tends to suggest that you're both knowledgeable and skilled in that, and you're going to routinely and reliably do it. And I think it's that we need to get to. So I think it's worth at least a debate.
Yes, language matters so much in this, doesn't it? Because it's sending messages. I remember many years ago reading a book by Ron Barnett, who's a professor at the Institute of Education, on the limits of competence and pointing out some of the problems with the connotations which go with the word.
Yes.
We're coming close to the end. We're going to overrun by maybe 5 minutes, but I realise some of you will have to get back to the coalface and continue in work. But we will finish by 5 past. So the next one is, that's an interesting one. It says, how can anyone join the team to explore ways of implementing? Who can I contact? Well, you can contact us via the website, and we'll be very happy to put you in touch with Bill and Emma, and you can play with them as Bill offered you. So tantalisingly earlier.
Thanks, Nick.
So the next question is, do you think quality improvement is probably better embedded in a practical learning environment as opposed to assessment-based environment such as a university exam? Which, again, you talked a bit about, didn't you?
No, well, I'm fascinated by the exam bit because there is something. It was a medical director who's been part of the Task and Finish group who kind of challenged me with it. And there is something about if you have some core, so for example, Part 1 membership, I mean, I've been asking a question, is clinical audit in there? But there is something about if it's in an exam, you will give attention to it. And there's something about the theory, there's the whole world of improvement science. And this is all just, I think it's all just piecing it all together. If you have it in your curriculum, if it is that you have, how well did the improvement project go? So I'm not talking about a pass and fail, about, did your project change the world all in 1 6-month time period, but much more, and we do have an assessment tool for core medical trainees on the ePortfolio, but it's much more about the learning that goes with it. And actually some of the most amazing learning has come from where things haven't gone very well. And I know that I've done lots of things that haven't gone very well. Doctors' uniforms spring to mind hugely at this point. But in terms of, there's something about if you have it in your curriculum, you have it in your assessment. If you were to have an exam, if you have it in your national recruitment and your appointability bit, that it's all jigsawing together, then you're creating that environment that hopefully enables trainees and maybe does push a few people that aren't quite with it. But I think it's about how you can be almost something to everybody, and that's challenging. But there is something for me about, we should probably be getting something about it in the exams.
Yeah.
So the university versus practice debate, I think, is a bit like the skill and knowledge versus habit debate. And I think it's a false opposite, although sadly in the lived experience it can be a real opposite. And I think increasingly universities and other research outfits, especially through the Clarks and the allied, you know what I'm going to say, AHSNs, sorry if that's a jargon for international listeners, are beginning to look at how we can have this kind of translational relationship in place. Emma had a lovely slide about contemporary workplace practices, and I think we use we paint from a too thin palette of possible teaching and learning methods, and we've got to get more imaginative there. So these longer, inquiry-led, coached, real-world learning assignments are much closer to what we need. And I think the language lets us down, because the minute we use a noun like exam, we automatically think exams are tested in this way. And we're not yet good enough at the complexity of work-based assessment. And I think that's where we've got to get a lot smarter, a lot sharper, because there are some people doing some really cutting-edge thinking in this area. And it has to be part of what we do. Seeing somebody walking the talk and actually doing this in a complex medical setting has to be where we're undertaking these assessments. So I think you're absolutely right to raise this question, Emma, and I just don't think we've yet quite got there. Would you agree with that?
No, absolutely. I think the problem is if you start to throw assessment in, then it feels like this pass-fail.
Yeah.
And the word formative and summative gets lost.
Yes.
But it's something about how do you see someone grow? And the challenge is that there is some, there's a data collection, and there's a lot of data collection that isn't actually that good and doesn't go anywhere. And there's something about how do you differentiate where someone is really using the data to drive improvement, they're really learning, they're growing, and they'll be using it as they go to think about their next problem.
I'd like to think that in the conversations we're having, we're mixing theory and practice.
Yeah.
As Kurt Lewin said, there's nothing so practical as a good theory, and there's probably nothing so theoretical as a good practice. And I think the more we get that sort of debate in real time, the better.
But I was very naive when I started, I think, because it was about, everybody's adult professionals, we want to go and improve, and here are the tools to do it with. Sorry, I hate all these words, tools to do it with. But actually, lots of them don't. They want you to be pretty didactic, and it's really fascinating with the trainees.
It is.
I've got increasingly prescriptive, which is slightly disappointing. But I think you have to enable. You've got to be big enough to enable how people work and learn differently.
Absolutely, and I think of a topic like statistics and statistical process control and run charts, and I can think of colleagues who can teach that in a effective but rather dull way, and colleagues who I can think of some of the Improvement Science fellows that the Health Foundation has, who can teach it in a thoroughly dynamic, engaging way that somebody for whom mathematics is not their first discipline utterly gets it. And I think there's another thing too about the university question. I'm slow at responding to you, Nick, here, which is that universities, of course, I guess like health trusts, organise themselves into silos. And in this complex area, we need some statistics, we need some sociology, we need some psychology, we need some hard and soft maths. We need, in fact, almost every discipline I can think of has something to contribute. And the danger is that we silo this off, or it becomes the premise of a particular tribe.
Yeah, you can go from anthropology to zoology and find things which are relevant to making things better. I'm going to have to call this to a halt now because we're coming to a time where I think we need to stop. The webinar and slides will be available to view on the website at the Health Foundation in the next few weeks. And I think we need to really thank Bill and Emma for a stimulating debate and for two presentations which really brought things together. It seemed to me when I came into this area of improvement that people are still using thinking from the manufacturing systems where you have a lot more data and control, and you're dealing with stuff which is invariant and which you can control and so on. And I think these advances which we've been hearing about today really help move us forward into the enormous complexities of healthcare. So it's goodbye from both of them. They did say if anyone was interested in playing, then do so. So this is real. We want to see how this stuff works in practice. We need people on the ground willing to commit some time to it. I hope that, to use Emma's term, this has been a bit of a virtual hug in terms of helping you think around these things and feeling a bit less exposed. I can say that the Health Foundation is about to announce a significant investment and improvement, and to tantalise you, read my blog on Monday, and hopefully that will tell you more about it and the way we're taking it forward. Thank you for joining us, thank you for sending in questions, and thanks again to both my speakers. Goodbye.
Thank you.
Bye-bye.